Welcome to the Wild Physio podcast with your host, Andrew Wild. Today I have Jared Powell on, and he's someone that a lot of people have reached out to me and they wanted me to get him on. So finally, here he is. Jared is an experienced musculoskeletal physiotherapist from the Gold Coast, Australia. Jared has an interest in shoulder pain and the shoulder joint and is currently studying for a PhD in this area. Jared teaches on the shoulder globally to critical acclaim. Jared has written several books and chapters within books, peer-reviewed articles, and presented at national conferences on a wide variety of topics, including frozen shoulder, rotator cuff-related shoulder pain, and shoulder instability. Not simply an educator or academic, Jared is also a clinician and runs a niche shoulder clinic on the Gold Coast. A huge welcome to Jared Powell.
Thanks, Andrew. Thanks for having me on, mate.
Really looking forward to it. As I said, there's been so many people ask me to get you on, and I've been following your podcast for a long time, or your YouTube channel. So props to you, mate. You're doing great work, and I love what you are preaching and what you're all about, and the evidence-based community, I feel like, is slowly growing.
No, I agree. No, thank you for supporting my work, and hopefully I can continue to churn it out over the next decades.
Sounds good, mate. Well, as I usually start my podcast, we're going to go with yes, no, or maybe questions. And then after it, we're going to delve into why.
Okay.
Let's do it. Is shoulder impingement a legitimate clinical diagnostic label?
No.
Should you trial conservative management before jumping into surgery for a first-time anterior glenohumeral dislocation?
Maybe.
Does upper cross syndrome exist?
No.
Can scapular mechanics change with physiotherapy intervention?
Maybe.
Does a frozen shoulder usually take 2 or more years to resolve?
No.
Is subacromial decompression surgery too common?
Yes.
Should you just get your shoulder stronger if you have shoulder pain?
Maybe.
If a shoulder improves from strengthening exercises, is it just because the person got their shoulder stronger?
Absolutely not.
Should we give a specific diagnosis when it comes to rotator cuff related shoulder pain?
Yes.
Is exercise just as effective as surgery or injection for rotator cuff related shoulder pain?
Yes.
Is there one exercise that is best for shoulder pain?
No.
Are there any bad exercises for shoulder pain?
Not at a global level, no.
Cool. Last one. Do people with shoulder pain versus people without shoulder pain have differences in subacromial space?
No.
Great. How'd you go?
Good. Yeah, no, they're good ones. Only a couple of maybes. I try to avoid the maybes, but no, good questions. All very important talking points, and most of them are misinterpreted by the community at large, especially within healthcare, which is frustrating, but I'll be happy to dive into some of those topics.
Let's dive into the first one, shoulder impingement. So going through university, I think I've been in practice 11 years and you're about 10 years or 11 years, a similar time. No doubt at university, you would have heard the shoulder impingement diagnostic criteria thrown around a lot. And you said that it really isn't a legitimate clinical diagnostic label. Why is that?
Where do I start? So go back in time. It was a observation that was observed by Charles Neer, the American orthopedic surgeon, in the 70s. He said that 95% of all rotator cuff tears were due to this mechanical impingement of subacromial structures underneath the overlying acromion. It was a fair enough hypothesis at the time. We've since gone on to test it, and it's not stood up to rigorous examination. We know that the onset of a rotator cuff tear is multifactorial and multidimensional, and probably the acromion impinging on the rotator cuff is the least important issue that we need to worry about in terms of the etiology of a rotator cuff tear. Not only that, we know that shoulders impinge in probably 1 in every 2 people in the world. Most of them are without pain. You can get better from your shoulder impingement, quote unquote, but your subacromial space or acromiohumeral distance need not change. It remains the same. placebo subacromial decompression surgery is just as effective as real subacromial decompression surgery, where the actual offending acromion is still in situ. So what does that mean for an acromioplasty procedure? So on and so forth. And then we're getting to the most important part of it, was when we actually interview patients and we try and find out, well, what does this diagnosis mean to you? And some of the comments that we hear from people who are diagnosed or given this diagnostic label of subacromial impingement are horrifying. They have visions of an acromion ripping into their rotator cuff and causing tears and fraying and all this horrible stuff. And we know that fear avoidance and kinesiophobia and patient expectations are super important for clinical outcomes. And why the hell will we set them up for failure by giving them a faulty diagnosis that is not really real in the first place? So for me, there's multiple levels of inaccuracies and fallacies associated with subacromial impingement.
So if someone's going to a clinician and they get told that their acromion is potentially an issue, and that's one of the reasons why they're getting that anterior shoulder pain or shoulder pain in general, if they're getting told that, what should they do? And should they go and see a surgeon? Should they go and seek another opinion from an evidence-based physiotherapist? What should they do?
Oh, that's hard, because I mean, I don't expect a lay person to know what the information that they're getting is right or wrong. Hopefully, so where I see it is we've got to change the perspective of healthcare practitioners first and foremost, because patients get their beliefs from healthcare practitioners 90% of the time. We think it's all about Google and the internet, and that is a contributing factor, but healthcare professionals are who patients trust and who they get their information from. So that's where I see my place, is trying to educate fellow healthcare practitioners, because I've been on the other side. I've been a proponent of impingement. I've told people that their subacromial space is reduced. I've told people that their motor control is faulty. I've told people that their scapula is not in the right position, driving their humeral head superiorly, causing impingement. I've been there. And I know it's not been supported by evidence. So it's hard for a patient. How are they to know that the information that they're getting is inaccurate? Of course, you could say you should seek multiple opinions, but not everybody's got the time or the financial means to go around and doctor shop or physio shop. So I think the biggest key is to get healthcare professionals reading the literature, especially the literature in the past decade, which is so convincing and comprehensive in refuting this subacromial impingement diagnosis. Now, unfortunately, what tends to happen is the patient with shoulder pain will go and see their GP. They'll get a scan. They'll see that there's a partial thickness tear or some thickening of the bursa. They'll get an injection. They'll try some basic exercises, maybe over a few months. If no better, then that care will get escalated to a surgical opinion. So a surgeon will say, look, there is a type 2 or type 3 acromion. Maybe we could do the subacromial decompression surgery. Patient will say, yes, let's get it done. The patient will improve. So then, has that been bad management? I don't know. At the N=1 level, maybe that person still has got a good result, but has it been the most cost-effective intervention? Could they have tried something less invasive and perhaps better for their overall health and well-being in terms of exercise therapy or something like that? So it's really hard, and I don't want to appoint blame to a patient because they shouldn't know. It all comes down to healthcare professionals for me, and we have to get better.
Yeah, agreed. So when it comes to that answer, in regards to the types of acromion, should we just rule it out and not even think about and not even label a certain type of acromion at all?
Yeah, it's a good point. So look, I don't want to diminish the role of the acromion. So we know the acromial shape, so type 2 or type 3, and then the acromial angle, which we call the morphometry, so something called the critical shoulder angle, is at least associated with having more chance of developing a rotator cuff tear. But it's just one dimension. Age is associated with rotator cuff tears. Sex is associated with rotator cuff tears. We've got genetics that are associated with rotator cuff tears. We've got activity levels. We've got occupation levels. We've got smoking. We've got all of these factors, metabolic syndrome, blah, 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 blah. I could keep going on and on and on here. All of these factors sort of go into the pot, and then pain and a rotator cuff pathology may emerge as a result of all of those factors interacting. Where I have a problem is that we reduce all of that complexity simply down to the appearance of the acromion on an X-ray. And I think that is a fool's errand in pursuing that. and neglecting all of the other variables that may influence the development of somebody's shoulder pain. So I don't advocate for the complete abandonment or forgetting of the acromion. I just think it should be considered in light of all of the other factors which may contribute to somebody's shoulder pain.
Yeah, really well said, mate. In regards to injections, so if someone's had an injection in their shoulder, everyone as a physio has seen this over the years where someone's come in and they said they had an injection and their shoulder felt better. How is that happening, and what is happening?
So great question. Mechanisms are really important here. So what's the mechanism effect of an injection? Now, I assume we're talking about corticosteroid injection.
Corticosteroid injection, yeah.
So inflammatory markers are found in the subacromial bursa. The bursa can definitely be a source of nociception with somebody with a sore shoulder. We know cytokines are found often in people with shoulder pain in the subacromial bursa. And then we also know that the biochemical milieu or environment of somebody's shoulder is altered, especially in the rotator cuff tissue as well. So these biochemical and nociceptive and classic biomedical type of variables are definitely still relevant in people's shoulder pain. So just throwing a load of corticosteroid in there is going to reduce that nociceptive firing, which may then result in a diminishment or reduction in that person's shoulder pain. But then we have to consider, well, what are all the other factors that could be driving this person's pain? What's their belief system like? What's their strength and conditioning like? What's their capacity and robustness like? What's their movement profile like? I still think movement is important here. What's their loading like? Are they just doing too much too soon? What's their sleep quality like? What's their diet like? Is it their dominant hand? Is it a technique issue in a tennis serve or something that we need to look at as well? So an injection can be a really potent reducer of shoulder pain, but we know that the evidence says that it works maybe 1 in 5 times, so 20% of the times, and that effect is usually lost by about 6 to 8 weeks when we compare it to a placebo injection. So the data is really underwhelming in terms of supporting a corticosteroid injection, and they're no better than an anesthetic injection as well. And there's also this discussion about the toxic consequences of a corticosteroid injection. We do have evidence, and that's the work of Benjamin Dean, that suggests that a corticosteroid injection can have catabolic effects on rotator cuff tissue as well. So, if we're going to throw this potentially toxic cocktail into somebody's shoulder, and it helps maybe 1 in every 5 occasions, and that benefit is lost after 6 weeks, I don't think that's really convincing evidence to trial an injection early on in the piece. Sure, we can try it later on if pain is persisting. And I think an injection serves as a nice middle ground between non-surgical intervention and surgical intervention.
So if you're not using the shoulder impingement clinical diagnostic label, what are you using? Because I've heard you obviously say on multiple podcasts and also your own podcast, rotator cuff related shoulder pain is something you use. Why do you think that is a good label? And why do you think you need to be somewhat specific when you are giving a diagnosis to a patient?
So yeah, I use rotator cuff related shoulder pain, and I sometimes use subacromial shoulder pain as well. Mainly the reason why I use a specific label is because honestly, patients come to us and they want some sort of explanation as to what's going on with their shoulder pain. And in my experience in the past, I have tried to give diagnoses of non-specific shoulder pain and shoulder pain, or you've got a weak and painful shoulder. And for me, they've just not been well received, even with the best explanation. So patients want some sort of coherent and articulate explanation that they can then go on and tell their friends about, tell their community about, tell their partner about. I have this issue of my rotator cuff in my shoulder, and I say rotator cuff in quotation marks. It's not all about the rotator cuff, but we can't neglect the role of the rotator cuff. As I mentioned a moment ago, we've still got a lot more research to do to look at the biochemical and molecular and cellular basis to shoulder pain as well. We might find, and we do have evidence, that people who do have shoulder pain have a higher population or density or volume of inflammatory chemicals within their rotator cuff tissue. And this may be flushed out or resolved by an exercise program. So before we start saying you just got to get stronger and you just got to do this and we've got to worry about structure, we need to kind of investigate this as well. We don't have strong research to say that all you have to do is get stronger, or the rotator cuff doesn't matter at all, so on and so forth. So whilst I'm an advocate that we need to progress away from a pure biomedical lens of managing people with shoulder pain, I don't think we should say that none of this matters whatsoever. And so coming back to this label of rotator cuff related shoulder pain, rotator cuff related shoulder pain does not implicate a pathology. It does not say your rotator cuff is torn. It does not say you have inflammation. It does not say that you have impingement, which we know can have nocivic consequences for a patient. It just says that you may have pain in your shoulder that most of the time, based on the research, might be related to your rotator cuff tissue and related structures. And then that is not to diminish the role of higher level phenomena such as psychosocial factors as well. So for me, it serves as a nice middle ground between abandoning diagnostic labels and just saying you have shoulder pain. So a patient comes in, hey, I have shoulder pain. Okay, your diagnosis is shoulder pain. I think that's underwhelming. And then saying you have this very specific diagnosis called subacromial impingement, and we need to fix that. For me, rotator cuff related shoulder pain, subacromial shoulder pain is a middle ground that still satisfies a patient's yearning and thirst for a coherent explanation, and also doesn't appoint a pathology or overt pathological diagnosis for a patient as well.
Every physio at some point has had a patient walk in their door, they've been to a GP, they've gotten an ultrasound, and they walk in and they say, I've got a swollen bursa. How common is a swollen bursa, and should it be something that we should be worried about as a clinician or even as a patient?
They're very common, first and foremost. If we see bursal thickening on the vast majority of people who are over 40 years of age, and especially in any age group in athletic individuals who are using their arm a lot, it's adaptive probably, and it probably changes when you use your arm a lot in a certain position. How relevant is it? Oh, I don't know. It's probably person by person. If you see somebody that is an elite swimmer and they're swimming, kilometers and kilometers per week, and they're just getting ready for some competition and they're upping their load, you're probably going to see some bursal thickening in that individual, and that bursa may be nociceptive generating or contributing to their pain. And if you were to go in and just inject that with corticosteroid, I guarantee you're going to help that person's pain. But how's that all going to sort of wash out in the end if you don't address some other risk factors as well in terms of loading, et cetera, et cetera. So I don't know at a global level the relevance of an inflamed or thickened bursa. I think it probably has some relevance, but I'll come back to my original point in saying that I don't think it matters more than other factors. And I think we can address the possible inflammation in the bursa while still addressing other factors as well. It just doesn't have to be all the other. But then we do have to remember, you can't just be loading this person up with 6 injections per year into a bursa without thinking about consequences to that as well. So, I think the bursa has a role, but the rotator cuff tear has a role, but just no more than other factors.
When it comes to rotator cuff related shoulder pain, when we look at treatment, a lot of the time I think that physios just want to get the thing stronger, get the shoulder stronger. Now, you mentioned that you should probably get your shoulder stronger if you have shoulder pain, but you don't have to get better, do you?
No, you don't have to. So people with rotator cuff related shoulder pain generally have weakness relative to the other side or relative to asymptomatic individuals. But where is that weakness coming from? Is it coming from pain inhibition? Is it coming from muscle atrophy? Is it coming from fear or avoidance? Is it coming from some other mechanism? So I will announce that yes, weakness exists, and it makes sense to try and correct that weakness and make that shoulder a little bit stronger. But is the mechanisms of trying to get that person's shoulder stronger contributing to their reduction in shoulder pain as well, or is a reduction in shoulder pain contributing to their increased strength? We don't know. We don't have firm evidence of causation there. So the popular groupthink ideology at the moment is that, for the last decade, which has been generally positive, is to get away from movement impairments, getting away from upper cross syndrome, getting away from pec tightness, getting away from scapular dyskinesis, and just making the thing robust and resilient and increasing the capacity. All of these tendinopathy terms, which have been really helpful in terms of progressing musculoskeletal care away from overly reductionist movement and motor control impairments. But what does that stuff even mean? Like, so we've not really investigated. We've just taken on this theory and we've not really thought about, well, is this person actually getting stronger? Or what is the causal mechanisms of this person getting stronger in response to a resistance exercise regimen? So we wrote a paper on this recently, and we actually had a look at, do people actually get stronger with a resistance exercise training program, for example? And sometimes they do get stronger, and sometimes this correlates to an improvement in pain and an improvement in function. But sometimes strength does not change at all. Like, there is a less than 10% change in strength. However, this person has a 50% reduction in pain and a 50% improvement in function. So what's driving that? So is strength a mediating factor in recovery? And at the moment, we don't have evidence to say yes or no. We have evidence to speculate about its association, but we need to actually go on and causally test this in a mediation analysis. And that's something I'm going to do as part of my PhD. We can draw upon other literature, such as low back pain and knee pain, patellofemoral pain. We know that hip strength is not a mediator of outcomes for patellofemoral pain. So you can improve somebody's patellofemoral pain by giving them hip strengthening exercises, but hip strength does not mediate improvements in outcomes for somebody's patellofemoral pain. So there's something else going on there under the scenes as well. And for low back pain, we know that erector spinae strength or extension strength and core strength is not a mediator of outcomes as well. Often we see mediators of outcomes in these, in low back pain, especially, as being kinesiophobia and fear avoidance and pain catastrophizing and all these psychosocial constructs, and not these biological constructs. However, I will say, in knee osteoarthritis, we do have evidence that quadricep strength is a mediator of outcomes. So increasing quadricep strength may be a mediator of outcomes in improving pain and function for knee osteoarthritis. And that was a study done by Hall in 2018. So the jury's still out. And in shoulder pain, we do not have causal evidence to say that strength is a mediator of outcomes at this stage.
Yeah, and I think some physios could potentially be too far down the line if you just got to get the thing strong, especially if someone comes in and they're already very strong. Do you need to add more load to an already overloaded program if they're starting to get shoulder pain from, say, a bodybuilding program or something like that? If someone does walk in your door and they are, say, a bodybuilder, or they do a lot of weightlifting and they're already quote unquote strong, what are you going to do then to manage someone's rotator cuff related shoulder pain?
A great question. So, I mean, let's not forget that overload is a significant risk factor for tendon pain. And I think a lot of rotator cuff related shoulder pain, is somewhat related to the rotator cuff tendon. So some of the biggest risk factors that we have for developing shoulder pain is an excessive increase in load from one week to the next. We have data on that, quite substantial data to support that claim. So if somebody comes into us, they're a gym goer, they're strong already, weakness isn't their issue, we need to figure out their loading history, what's happened over their past 4 to 6 weeks, has anything changed? And that's not just physical loading, what's their psychosocial and psychophysiological load over that time as well? Has anything changed? Because a change in psychophysiological load is just as big of a risk factor as a change in physical load or external load as well. So external and internal load. So we need a full history on how that person presents to us. Has anything changed? Often there will be some sort of psychophysiological or physical change in their loading profile over the past 4 to 6 weeks. And then we need to modify that. We need to change that. We don't just give them, all right, do this side lying external rotation exercise and you're going to be better, because that person, it's just not part of their clinical profile. And so obviously it's hard to speculate at a global level or a population level about what needs to be done, but often there will be something within their clinical presentation that is somewhat different, perhaps, to what's been done over the preceding few months. And then we look at that. If there isn't, then it's challenging. You need to be a good clinical detective here and try and figure out, okay, you're getting pain when you do this movement. Can I modify that movement? And does the pain get better? Symptom modification gets a bit of a bad rap, but I think it's super important. If you have pain when you do an abduction movement and you can do flexion, okay, and you can't do lateral raises, but you can do a scaption raise or a front raise, then you just calm that movement down. This is the old Greg Lehman thing: calm it down, build it up, or a graded exposure program as well. So you don't need to like specifically go, okay, I'm going to increase your abduction strength. What you could do is go, okay, I'm going to do a graded exposure program into abduction here to try and reduce your pain in that direction. Or I'm just going to avoid or reduce that movement for a bit in your training and focus on other raising movements, and then get back to it in a period of time and see how it goes. So it's just can't be as reductionist and going, okay, you're coming in, you're weak, I get you strong and you get better. It's just silly when we know how complex pain is.
Yeah, really well said, mate. When it comes to exercises, you said that there's no one best exercise for shoulder pain, and there isn't necessarily a bad exercise for shoulder pain. Just quickly dive into some of the shoulder exercises that you do use when you have someone with, say, rotator cuff related shoulder pain. What are your go-tos and your bread and butter when it comes to prescription?
Yeah, so there's obviously like infinite exercises you can do. However, I kind of cycle through like 10 of the same exercises all day, every day. And I'm not afraid to say that, because the shoulder, you don't need, these sexy exercises that we see on social media are not more effective. And in fact, I reckon they're a barrier to getting better a lot of the time with shoulder pain, because we know the biggest barrier to participating in resistance training is complexity from a patient's perspective. So I like to keep it really simple. So honestly, I divide it up into like irritable and non-irritable. When somebody's really irritable, I use highly controlled exercises in like the sagittal plane or the rotation plane. And that's usually like a front raise or a lateral raise or a pushing movement or a pulling movement, and then maybe an external rotation movement as well. And I will progressively make that harder. I usually start low load, high rep. And I usually, even in the irritable phase, and some people won't like this, I take them close to failure. I take them close to fatigue. I like that exertion. I like that intensity, because I like to get them feeling that burn going, because for a long time they've avoided it. And I often find that patients say it feels so good to be getting that burn in the shoulder again. And that increases their confidence and perhaps incentivizes them to keep going with their exercises. So in the highly irritable or highly controlled stage, I use basic push, pull, and rotation exercises. And then when we're getting into the non-irritable phase, I use more chaotic movements. And then we might be progressing down into the more hypertrophy kind of load, or the plyometric or power load. We start overhead raising. We might get back into bench. We might do some upright rows. We might do some landmine presses, so on and so forth. We might do some closed kinetic chain exercises again. We might do some full body, lower limb, integrating kinetic chain stuff as well. So, and it depends on what the person gets back to. The person's 70 years old and wants to swing a golf club, mate, they can literally do a rotation exercise, a lateral raise, and that's probably it. Once they've got their requisite range and function back, they don't need to do more. If they're a swimmer, if they're a baseball thrower, they might have to do a little bit more. But for me, I've got a core set of basic exercises. I cycle through them, I progress them, and I match them to the person's demands. It's as simple as that.
Amen to that. I use the exact same sort of framework, and it works well. It works well. Simple is often good. I don't think we need to complicate things.
Yeah, I agree.
Now, when it comes to bench press, a lot of people will have a little bit of shoulder pain at some point potentially in their life with bench press. What should you do if you have shoulder pain with bench press? And we're talking typically anterior shoulder pain. People come in and they say that it started to hurt for the last month or so, and I pushed through it because I love bench. Monday's bench day. What should they do?
Yeah, well, look, it's so common, right? I hear everyone come in, they've got anterior shoulder pain, benching hurts it, and everyone thinks it's the long head of biceps straight away, right?
Yeah.
Every time, because it makes sense. It's there. What's under there? They Google it, long head of biceps, and then the gym guys, the S&C guys, no offense, will say that as well, because that's what we're taught. And, sometimes there might be a bit of long head of biceps tendinopathy or tenosynovitis for sure. Usually for me, the biceps is a victim at the scene of the crime. Something's happened with the rotator cuff, which has led to a little bit of overload going through that biceps tendon. So if somebody comes in, they've got pain with benching, it's anterior shoulder pain. What do we do? So firstly, like, are they a power lifter? Are they competing in a comp coming up where they need to bench? Or are they just as you said, a kind of, love going to the gym, Monday's bench day, and they just enjoy it. So if it's the latter, if it's not an essential part of their life and they earn money from it, then we just need to adapt that pushing movement. And often I can always find a pushing movement that is pain-free in an individual who has pain with a bench press. So if they really want to keep a pushing movement in their program, I'll find it. Honestly, I'll find it. And usually that is just simply lying on your back, doing like a punch the ceiling press movement.
Yep.
That's usually pain-free because it puts not much load through the shoulder, but it is still a pushing movement. Or sometimes just a landmine press in a similar position can be pain-free as well. Usually it's provocative when you get out into that classic sort of 67 degrees abduction movement. That's when you get a lot of load through the shoulder. So if often the first thing I try and do, somebody presents to me with pain and bench pressing, I'll modify it, see if I can keep them doing a pushing movement, and then I'll try and reintegrate that bench press as soon as possible. But I'm honest about expectations here. This may take 12 weeks. This may take 16 weeks of you doing these kind of boring pushing movements that aren't satisfying you as much as bench pressing. But eventually we'll get back there once you've earned the right, once your shoulder is less irritable, once you've calmed it down, and once we've gradually exposed you to that stimulus again. However, if it's a power lifter and somebody wants to get back into elite powerlifting, or they've got a heavy meetup, it's really hard because pain, often that's when you might need to look at more medical interventions there, such as an injection or such as medication, or just trying to push through the pain as best you can there. And so different populations require different interventions and different thinking. But if it's just the everyday bloke or woman who wants to go to the gym and bench on a Monday, there are ways to keep them pushing without doing bench press.
Yeah, agreed. Landmines are great. And I think something that people miss too often in programming is push-ups. Don't you think push-ups have just fallen by the wayside, and everyone 100%. Thinks that push-ups are not as good as, say, bench, or they're just not as hard or whatever? Do you think people just miss the point with push-ups? And, even weighted push-ups, they're just so powerful and such a great exercise.
Yeah, probably my favorite exercise to do generally for my upper body. They're unreal, and they're a great sort of metric of health too, and longevity. So being able to do push-ups, it means that you're a healthier person. And also if you love EMG, which I don't, but if you look at the EMG studies of push-ups, they actually activate the rotator cuff more than a scaption raise or a lateral raise. So push-ups are a great way to rehab rotator cuff related shoulder pain. And they are neglected probably because they're too basic. Yeah. And for us intelligent physios who have done 5 years of training and this and that, and we'll read journal articles, they're not stroking our ego enough. But for me, a push-up is a key part of my rehab.
Yeah, and it's such an easy way or an easy exercise to regress and progress. You could start with an elevated push-up and then slowly work them down the rack and then eventually onto the ground, and then you can do weighted push-ups. I think they're great. The other thing, obviously, you can change is depth. Depth is obviously a modifiable factor that you can change with either a push-up or a bench press, and doing things like a board press, or even like getting a towel and rolling up a towel so it's as big as a drink bottle and sliding it up in between your chest and your shirt and then going down to there rather than going all the way down. I find that really helps people just to slowly integrate back into bench. But I think anecdotally as well, men will often push themselves a little bit further with a bench press because of the ego. So often going to something like a board press or going for the towel is a good way to slowly get them back, rather than, just getting them back into full range straight away after they do a period of, say, landmines or push-ups or something like that.
Yeah, 100%, mate. Agree with you.
Now, let's dive. Actually, one more question on that. When it comes to someone with rotator cuff related shoulder pain, should you be pushing them into pain while they're doing their exercises?
Good question. At a population level, I don't know. Sorry, at a population level, just reverse that. At a population level, we have evidence that suggests that going into pain might be actually a little bit better than avoiding pain.
And so how much pain are we talking about here?
Yeah, so that's it, right? So when you look at the literature, it's different in terms of how people actually measure it. Some people say 3 out of 10, some people say 4 out of 10, some people say 5 out of 10. Some people say as long as it's tolerable to you. Some people say 5 out of 10, but no worse the next day. It's heterogeneous, like everything in physiotherapy. It's all mixed because we're a young profession and scientifically young as well. We're getting better, but the literature's pretty shit. So how I approach it is you can have pain. It must be tolerable to you as an individual, and you need to figure that out. I'm not going to reduce it to a number on a 0 to 10 scale. I just think that's a bit absurd because pain is a subjective emergent variable. And then we're like, okay, but what is it? What is it out of 10? It's got to be a number.
Yeah.
It's a bit silly when you think about it. And I know why we use it, because we don't know what they're experiencing. So it's a way of kind of like trying to get into their head a little bit. Anyway, I just say, if it's tolerable to you as an individual, then carry on. It needs to be no worse within a few hours afterwards. If you're having a huge flare up that evening and the morning after, it's too much. Okay. Then we need to titrate it down a little bit. But I don't seek out pain in my rehab. I don't look for a movement that hurts.
Yeah.
But if a movement is particularly valuable to an individual and they want to do it and it hurts a little bit, it's no worse the next day and the next morning, then I will permit pain in that particular movement. So, but it just depends. If somebody's highly strung, highly catastrophizing, highly anxious, and any little bit of pain they are not responding well to, I totally respect that. And I don't like this paternalistic nature of healthcare where I'm like, no, don't worry. The literature says it's fine. You're not going to hurt your shoulder. Like, you don't know what the fuck that person is experiencing right now. You don't know where it's come from. You don't know what their childhood was like as to how they're experiencing pain. So you don't get to just shut them down and say it's fine based on all of these RCTs that are done on 30-year-old men. So I totally respect that, and you have to gauge it from an individual perspective. And I know that sounds obvious, right? But it truly is. And I see far too many clinicians these days who are way too far down this empiricist kind of rabbit hole when they're like, this systematic review said that I have to do 3 times 8 and then it's effective. It just when you take it down to an individual within all those 2,000 people's in that meta-analysis, there will be variable responses. And then we just average it all. And that's how we get this overarching effect size, So there is still individual variance. And that's when it's great to be a clinician. This is the art of being a clinician, because we have to apply the empirical data to the individual in front of us. And for me, that's why I love being a healthcare professional. Because it's not one or the other. You don't just go, oh, nah, stuff what the evidence says. I'm a guru. The science will catch up with me one day. I'll go, no, this is what the meta-analysis says. You have to combine both. And that's why I don't get these arguments on social media that are obsessed with one or the other.
Yeah, agreed. It's a bit of a blend of the science and the art, isn't it?
Totally.
That's what you need to do, for sure.
I call it the artful application of science. And that's what you need to adhere to.
For sure. When it comes to these exercises that we're doing for someone with some shoulder pain, you said in the yes, no, maybe questions that scapular mechanics aren't changing with physiotherapy intervention or exercises. Why is that the case? And what research has changed your thinking in the last 10 years?
Yeah, so when we look at almost every single clinical trial that's done that has applied some form of intervention, usually motor control intervention or resistance training intervention to people with perceived scapular dyskinesis, what we'll see is that person, and it's usually a 12-week program, that person will have reduced pain, increased function, but their scapular kinematics will remain unchanged after 12 weeks. And this is every single clinical trial, like randomized controlled trial in people with a perceived scapular dyskinesis. And this is not even, I don't even want to talk about the reliability of assessing a scapular dyskinesis and all of that as well. So just when we apply an intervention, we know that scapular kinematics need not change in order for somebody with rotator cuff related shoulder pain to have an improvement in function or an improvement in pain. It's as simple as that. Now, this might change because, again, we've not really causally investigated this. We're only seeing this in like association trials. All right. We're just seeing that scapular kinematics doesn't change, but their pain and function does. And then we're like hypothesizing. Then we're like, well, maybe it doesn't work, but we need to do a mediation analysis to causally analyze this. All right. And we haven't done this in shoulder pain, which is a big part of the literature that's lacking in regards to shoulder pain. And I don't even know, and I don't want to say that exercise can't change scapular kinematics. Maybe it can, but I just don't think it needs to, based on the evidence that we have at the moment. And I don't think it really needs to be a core intervention target when somebody comes to us with shoulder pain. I'll honestly have a look at the person's scapular movement. If it's not foul and making me vomit in terms of how bad it is, then I will not look at it again.
Yeah.
And I'll just try and get that person stronger or increase their capacity.
It's effectively ruling out the howler,
Yeah.
As you said.
Totally.
A disgusting looking scapula.
Exactly. In which case it might be a nerve palsy or something like that. And then you need to definitely figure it out. But if you're like, oh, is it 2 degrees out relative to the other side? Is the upper trap firing slightly earlier than the lower trap? You got no idea. You're lying and you're using confirmation bias because you think that is associated with somebody with sore shoulder.
Completely agree, mate. Last question. So I asked you, should you trial conservative management before jumping into surgery for a first-time anterior glenohumeral dislocation? You said maybe. Why?
So it depends on age.
Yep.
Depends on what sport they're engaged in. Depends on if they want surgery. Depends on their structure. So if they have a bony Bankart lesion that's significant, then that person will get a better result in terms of redislocations with a surgical intervention. And that surgery will be a Latarjet procedure as opposed to just a Bankart repair procedure. If somebody is under 20 years of age or under 25 years of age, then that person will probably get a better result just in terms of redislocation rates with surgery. I don't know if they'll have a better quality of life with surgery, and there's evidence to say that maybe they won't, but their dislocation rate will be less with surgical intervention. If somebody is particularly a young male who is participating in contact sport and they have evidence of a Bankart lesion in their shoulder, bony Bankart or a labral Bankart lesion, I will be suggesting that person should go on and have a surgical opinion for a surgical intervention here. Now, you asked, does somebody need to have a surgical intervention for a first-time shoulder dislocation? And we're saying a traumatic shoulder dislocation here. An atraumatic dislocation is a bit different, but a traumatic anterior shoulder dislocation. The evidence says that you can trial non-surgical intervention here. And if they keep redislocating, so if they dislocate it twice or 3 times over 1 or 2 years, then that trialing that non-surgical period is not going to make their outcomes worse. So if they were to have surgery first versus having it after a couple of dislocations, they usually still do have similar outcomes in the long haul.
And how long would you be trialing that?
It depends on the person. I'll give it 6 to 12 months. The data says that if you are going to redislocate, 90% of the time you redislocate in the first 2 years. If you avoid it in the first 2 years, there's less and less chance that you're going to redislocate again. So obviously you don't go 2 years, but I use sort of 6 to 12 months as a metric there. And I at least go, but however, I just had a guy come in the other day. He's got a bony Bankart lesion. He's 25 years old. He plays rugby. I said, mate, I really think you should go and have a surgical opinion here based on all of these things that you're showing. He's already redislocated his shoulder 6 times before he even saw me. And he's a roofer as well. So all of these things mean that he needs his shoulder, and I don't think it's going to get any stability from just some motor control exercises.
Yeah. If someone walked in your door exactly like that guy and financial problems was potentially a barrier for them getting surgery, what options would they have?
In regards to sort of physio versus surgery?
Well, if they couldn't afford the surgery, they didn't want to have surgery, they didn't have access to surgery, if they were in a really remote community or they lived somewhere that didn't have access to surgical intervention, what options would someone that continually dislocated their shoulder have?
Well, then it comes down to us. It comes down to exercise. It comes down to non-surgical rehabilitation. And there is evidence to manage that. So the big systematic review that was done in 2018 by Kavaya, I think in Finland or Norway or one of the Scandinavian countries, suggests that if you have a first-time traumatic shoulder dislocation, physio can be effective in reducing that dislocation, like a redislocation 50% of the time. That's still a big number, you know? So like it's not as good as I would like, and it's not as good as surgery. It's kind of a coin flip whether you'll redislocate again, but it's not insignificant. So you can say to a person, and there are actually sort of impairments or physical factors that are associated with redislocation as well. So weakness is actually associated with recurrent instability of the shoulder. Proprioceptive deficits are associated with recurrent instability of the shoulder. And so there are things that physiotherapists can target and intervene and try and change that might reduce their chance of a redislocation down the line. So if surgery isn't an option, then you're stuck with some sort of exercise-led intervention. And then it comes down to the physiotherapist to adequately screen what's going on, what can I change here? And after a first-time dislocation, we have evidence that not using a sling can actually increase the chance of a redislocation down the line, but there's no more benefit to I believe, I think the number is 7 to 10 days of using a sling. So there's no more benefit going beyond 7 to 10 days of using a sling versus within that time frame. So I'll usually advise someone to sling their shoulder for like 10 days, 2 weeks. And the evidence says that if you sling it for less than that, or not at all, if you don't sling at all, then there's an increased chance for a recurrent dislocation. So there's still many things that physios need to know about in terms of managing dislocations and then targeting to try and reduce that risk of a recurrent dislocation down the line. But I will say it's not going to be as effective most of the time in a young person, in an athletic person, in reducing their recurrent dislocation rate for surgery.
Yeah, well answered, mate. Well, thank you so much for coming on. My last question is, have you got any advice for student physios or new grad physios that are just starting work? Because I've heard you talk about your existential crisis that you had 2 or 3 years out of uni, and I had something similar as well, where I wasn't sure what I wanted to do going forwards. What is your advice?
I think everybody says the same stuff. It's like, be a critical thinker, keep reading, do all this. But honestly, I don't know if my existential crisis was a bad thing. I think it was a good thing. I think I'm happy that I did the hard yards early in my career. I had to unlearn some stuff. I had some moments of stress. I had some moments where my worldview was getting disrupted or violated completely, and I had to update my thinking. And so I'm better for that. And I don't know if I want students to actually be immune from that. I think I subscribe to this theory from Nassim Taleb called anti-fragile, where we should respond to stress and suffering by getting better from it. We shouldn't try and avoid that. We should try and build ourselves up from that kind of uncertainty and that distress and that worldview or existential crisis that we go through. So I still think that students, because they're still being taught the same stuff, they have to go through that process of being confronted with stuff that opposes their thinking. That's how we update our beliefs about the world, especially when you look at the predictive process framework, where the only way to update our beliefs is being confronted with prediction errors or things that actually go against what we think. So the advice that I have from students is to graduate, go out, do what you want to do, get a job first, earn some money, stop being a student, get a wage, try and help some people, and then test the theories that you were taught. This is the heart of the scientific process. This is what Karl Popper said we must do. We have a theory and then we test it. And then we, in an open-minded way, we look at the outcome of that test and we analyze it. Does the test actually respond to our theory? Does it support our theory, or does it falsify our theory? If it consistently falsifies our theory, such as impingement, which is what happened to me, then you have to go on and read about it. You have to go on and investigate about it. And then you have to present an alternative theory and then go and test that. And if you are a scientifically minded clinician, or a clinician scientist, as Steve Camper calls it, then this will be the case throughout your entire career. You're not going to know it ever. I'm still testing theories in the clinic daily. I'm refining it. I'm getting better. I'm better now than I was a year ago. And I plan for this to keep happening until I'm 95 years old. And so I guess that's my advice. Be comfortable with uncertainty. Be comfortable in the gray. Keep testing your theories. Don't hold them too closely or too tightly. this whole thing of science doesn't give a fuck about your feelings is totally true. And just so separate your ideology from your feelings a little bit. And then just keep testing them over the years and the years, and you're going to get gradually better. You're going to approximate the truth eventually.
Great advice, mate. Now, where can all the listeners find you? And if they wanted to, say, do one of your courses or anything like that, where do they find all that sort of information?
Shoulderphysio.com is my website. Nice and easy. I'm just redoing it. I had to pay a lot of money to get that domain name. So shoulderphysio.com. And then Instagram, shoulder_physio. Twitter, sometimes Jared Powell 12. And that's sort of the best social media or internet platforms to get me on.
Great. Well, thanks again, mate. It's been a world of knowledge, and you've been really generous with your time. So thank you very much.
Thanks, Andrew. Nice to meet you. Thanks for having me on, mate.
My pleasure. And as usual, stay strong.